Welcome to the Deep Dive, the show that's all about giving you the most critical knowledge you need, but, delivered in a way that actually makes sense,
Mm.
especially if you're gearing up for a big exam or a clinical challenge. You kind of need that shortcut to being genuinely informed.
And today we are really taking on a beast of a topic, congenital heart defects, or CHDs.
It's a big one.
It is. But our mission today is to give you a really high-yield masterclass. We're going to focus completely on the clinical reasoning behind it all, so you can move past just memorizing names and actually start predicting what you're going to see.
And we should say right up front, this is a heavy topic. I mean, CHDs are the most common cause of death in the first year of life right after prematurity.
Absolutely. So this isn't just academic. This is, life and death knowledge.
For sure.
And to make it manageable, we have to organize it. The only way through this is to classify the CHDs by how they change blood flow. This is the cheat code. So you should probably organize your notes this way. We're hitting 4 groups in order.
Okay, what are they?
First, increased pulmonary blood flow. We'll
Yeah.
call it IPBF.
Got it.
Second, the opposite, decreased pulmonary blood flow, or DPBF.
Okay.
Third, the really complex ones, the mixed defects. And finally, number 4, obstructed systemic blood flow.
Perfect. A clear roadmap. So where do we start?
We have to start before the defect. We have to start with the blueprint. You can't understand what's broken until you know how it's supposed to work.
You mean fetal circulation?
Exactly. This is non-negotiable.
Yeah.
You have to understand the fetal plumbing. Remember, in utero, the lungs are they're not in the game. They're filled with fluid, super high resistance. So the whole system is built to just bypass them.
Right. It's all about detours. I know there are 3 big shunts, but they can be confusing. Let's walk through it step by step. Where does the good oxygenated blood come from?
It comes from the placenta, through the umbilical vein. And that's a key point right there, a classic test question. The umbilical vein carries the oxygenated blood to the baby.
Okay, so that blood heads toward the liver.
It does, but it takes the first shunt, the ductus venosus. This diverts most of that beautiful oxygenated blood away from the liver and sends it right up into the inferior vena cava.
And into the right atrium. Now, in you or me, that blood would go to the right ventricle, then the lungs. But you said the lungs are offline.
They are. So we hit detour number 2, the foramen oval, or FO. It's basically a little flap, an opening between the right atrium and the left atrium.
A one-way door.
A perfect one-way door.
Yeah.
Because pressure on the right side is higher than the left in utero, it pushes that oxygenated blood straight across into the left atrium, bypassing the whole right side of the heart and, critically, the lungs.
Okay, so now that super oxygenated blood is on the left side, goes to the left ventricle, out the aorta, and where does it go first?
To the most important places, the brain and the upper body, the coronary arteries.
But what about the rest of the blood? The deoxygenated blood coming back from the baby's body that mixes with a little of the oxygenated blood. Some of it has to go to the right ventricle.
It does. And that mixed, less saturated blood heads out toward the pulmonary artery. But it hits our third and final shunt, the ductus arteriosus, the DA.
The big one.
The big one. It's a major vessel connecting the pulmonary artery directly to the aorta, so that blood just completely bypasses the lungs and goes down to perfuse the lower body, and then eventually back to the placenta to get reoxygenated.
It's an amazing system for life inside the womb, but then the baby's born, that first breath, it changes everything, doesn't it?
It's the most radical hemodynamic shift a human ever experiences. The second that baby takes a breath, the lungs inflate, and that pressure, that pulmonary vascular resistance, just plummets.
So blood just rushes into the lungs for the first time.
Brushes in, and all that blood comes back to the left atrium. Suddenly, left atrium pressure is way higher than right atrium pressure.
Yeah.
And that pressure difference just slams the door shut on the foramen oval.
Wow. And the ductus arteriosus, what closes that?
Oxygen, just plain old oxygen from breathing air. It's a powerful vasoconstrictor for the muscle in the DA's wall. So it starts to clamp down within hours to days after birth.
Okay, here's the huge clinical question then. If these things close so fast, why do we hear that symptoms of many CHDs don't show up for like 4 to 12 weeks? What's that gap all about?
That is such a critical concept for any exam. The closure is functional at first, but it's not permanent. It's not anatomical yet. So for those first few weeks, the DA and FO might be functionally closed, but they can still act as a pop-off valve.
A release valve.
Exactly. If a baby has, say, a big VSD, that ductus arteriosus is acting as a temporary shunt, masking the true pressure of the defect. But once those fetal shunts close for good, usually around that 1-month mark, the full force of the defect is unleashed and boom, the baby crashes with heart failure.
The temporary shunts were hiding the problem.
They were hiding the severity. It's a classic timeline.
That makes so much sense. Okay, before we dive into the defects, let's quickly hit the big risk factors. What patient populations make you immediately think, I need to look closely at this heart?
First, just remember, the most common CHD overall is a ventricular septal defect, a VSD.
Okay.
But for specific syndromes, you have to know these cold. Trisomy 21 Down syndrome. Almost a 50% risk of a CHD, and the one you should immediately think of is the atrioventricular canal defect, or AV canal.
So Down syndrome, think AV canal.
Absolutely. And then there are the environmental links, fetal alcohol syndrome, another 50% risk, infants of diabetic mothers, about a 10% risk, often VSD, or a really tough one, transposition of the great arteries.
And maternal infections.
The big one is rubella. A maternal rubella infection in that first trimester is highly, highly linked to patent ductus arteriosus, PDA, and pulmonic stenosis.
Okay, foundation laid. Let's get into group 1, increased pulmonary blood flow, IPBF.
Right. So we're moving from the why of the circulation to the what happens when it's wrong. And for this first group, the big idea, the physics of it all, is the left to right shunt.
High pressure to low pressure.
Always. After birth, the left side of the heart is the high pressure system pumping against your whole body. The right side is low pressure. It only has to pump to the lungs next door. So if you have a hole between the two sides...
The blood's going to take the path of least resistance.
Yeah.
From left to right.
Exactly. So you have this freshly oxygenated blood that just came from the lungs. And instead of going to the body, a bunch of it gets shunted back to the right side and sent to the lungs all over again.
It's like rewashing clean laundry.
It is. You're over-circulating the lungs, just flooding them. It's inefficient and causes a ton of problems.
But since the shunted blood is oxygenated, the baby won't be blue, right? They're acyanotic.
Correct. Not blue. But they are showing all the signs of volume overload. Their lungs are wet. So clinically, what you see is a baby who is tired, breathing fast, getting frequent pneumonias and respiratory infections, and just not growing. Failure to thrive.
Because all their energy is going into breathing.
All of it. It's an incredible metabolic cost.
Okay, let's start with the first defect in this group. Patent ductus arteriosus, the PDA.
Right. This is simply the failure of that fetal shunt between the aorta and the pulmonary artery to close. The aorta has systemic pressure, way higher than the pulmonary artery.
So blood is constantly shunting from the aorta back into the pulmonary artery.
Constantly. During spusally when the heart pumps and during diastole when it rests.
Mm.
And that continuous flow is what gives you the classic finding.
The murmur.
The murmur. It's a continuous machinery murmur.
Mm.
It literally sounds like a washing machine running nonstop. Best heard at the upper left sternal border.
And what else would you see?
Just as important are the peripheral signs. Full bounding pulses because of all that extra volume and a widened pulse pressure.
Why widened?
Because the diastolic pressure drops. Some of the blood that should be in the aorta maintaining that pressure is leaking back into the pulmonary artery during diastole. So the gap between systolic and diastolic pressure gets bigger.
Got it. So how do we fix it? What's the medical approach?
For preterm infants, we use IV ibuprofen or indomethacin. They're prostaglandin inhibitors. Prostaglandin is the chemical that keeps the DA open in utero, so blocking it encourages closure.
But there's a huge safety point here, right? A contraindication.
Massive. You cannot give these meds if the infant is already in severe CHF. Closing that PDA suddenly could just completely overload the left ventricle and make things way worse.
So what if meds fail, or it's a term infant?
Then it's either surgical ligation or, more commonly now, a transcatheter closure in the cath lab. And the prognosis is great as long as you fix it before that chronic overload causes permanent pulmonary hypertension.
Okay, next up, atrial septal defect, ASD.
Right, a hole in the atrial septum, a left to right shunt. But the pressure difference between the atria is much lower than between the ventricles.
So the symptoms would be less dramatic.
Exactly. That's the key. Small or moderate ASDs can be totally asymptomatic for years. These are the kids who just seem to get sick a lot of respiratory illnesses because their lungs are just a little bit wet all the time.
So what's the telltale sign on an exam?
The auscultation. It's a soft systolic ejection murmur up in the pulmonic area, but the classic finding is a fixed, wide splitting of the second heart sound, S2.
What does that mean, fixed, wide splitting?
Well, S2 is the sound of the aortic and pulmonic valves closing. Normally they close almost together. With an ASD, there's so much extra blood on the right side that the pulmonic valve closes later. Because that extra volume is constant, the split between the two sounds is fixed. It doesn't change when the child breathes in or out.
Interesting. And how do we treat these?
Many small ones close on their own in the first few years. For larger ones, they can now close many of them in the cath lab with a device called a septal occluder.
Is there a safety point post-procedure?
Yes, the child will be on a low dose of aspirin, 81 milligrams a day, for about 6 months. That's to prevent any blood clots from forming on that new device.
And what's the big deal about fixing an ASD even if the kid seems fine? What's the long-term risk if you don't?
Stroke. As an adult, it's a huge risk. If a tiny clot forms somewhere in your veins, it normally gets filtered out by your lungs.
Yeah.
But with an ASD, that clot can cross from the right atrium to the left atrium and go straight to your brain. It's called a paradoxical embolism.
Wow. Okay, that's a serious reason. Now, on to the VSD, ventricular septal defect, the most common one.
Yeah, most common, yes. A hole in the ventricular septum. And here, the pressure difference is massive. Left ventricle pressure is like 5 times higher than the right.
This shunt is really forceful.
Very forceful. With a small VSD, the hole is restrictive. It actually creates a lot of turbulence, so you get a very loud, harsh murmur, but maybe not a huge amount of shunting.
But a large VSD is a different story.
A completely different story. A large, non-restrictive hole means the two ventricles basically become one big chamber. You get a massive shunt of blood to the lungs. These are the babies who get into severe heart failure very early. Poor growth, constant respiratory infections.
And the murmur for this one.
It's the classic, loud, harsh systolic murmur. You hear it at the third or fourth left intercostal space, right along the sternal border. You can often feel it, too. That's called a thrill.
Do these close on their own like ASDs?
A lot of the small ones do, yeah.
Yeah.
About 80% close spontaneously in the first 6 months. But if it's large and the baby is really struggling, surgery is the only option, usually after they're about 6 months old.
You mentioned a risk of arrhythmias after VSD surgery. Why is that?
Because the heart's electrical conduction system, the bundle of his, runs right along the ventricular septum. So when the surgeon is in there patching that hole, it's very easy to accidentally damage those pathways.
Which can lead to, well,
Bundle branch block, or even a complete heart block. And that might mean the child needs a permanent pacemaker.
what happens if a really large VSD is just left untreated for years?
This is a huge testable complication. It's called Eisenmenger syndrome. The constant high-pressure flow to the lungs eventually causes the pulmonary arteries to remodel and thicken. They become scarred down.
And that leads to permanent pulmonary hypertension.
Exactly. And once the pressure in the lungs gets higher than the pressure in the body, the shunt reverses. It becomes a right-to-left shunt. The child turns blue. But now it's too late. The lung disease is irreversible. You can't operate. It's the point of no return.
Chilling. Okay, last one in this group. The atrioventricular canal defect, AV canal, the one you said is linked to Down syndrome.
This is the most severe of the IPBF defects. It's not just one hole. It's a huge central hole where the atrial septum, the ventricular septum, and the mitral and tricuspid valves all fail to form correctly. It's one big defect in the center of the heart.
So you have mixing of blood everywhere and massive volume overload.
Massive. So the symptoms are profound, and they start early. Severe CHF, tachypnea, tachycardia, and just a profound failure to thrive. They were working so hard just to breathe.
And what does the murmur sound like?
It's a holosystolic murmur, meaning it lasts through all of systole at the left lower sternal border. And on an EKG, you'll often see a really long PR interval.
With a defect this severe, you have to operate early to prevent that Eisenmenger syndrome.
Very early, usually between 2 and 4 months of age. And because it's such a complex repair with a lot of patch material, there's a key nursing point for parents.
Which is?
Infective endocarditis prophylaxis. They need antibiotics before any dental work or other procedures for at least 6 months after the surgery.
Okay, that covers the first group. It seems like heart failure is the common destination for all of them.
It is. So we need to do a quick high-yield review of how to manage heart failure in these kids.
Perfect. Let's start with recognition. What are the big signs we need to look for?
Think in threes. 3 triads of symptoms. The first is systemic venous congestion. That's fluid backing up into the body.
So edema.
Yep. In babies, look for periorbital edema, swelling around the eyes. Also a big liver, hepatomegaly.
Okay. Triad number 2.
Pulmonary congestion. Fluid backing up into the lungs. This is your classic tachypnea, grunting, flaring, retractions, wet, crackly lungs.
And the third one.
Impaired myocardial function. The pump itself is failing. This is where you see tachycardia. That's a really early sign. Cool. Pale skin, weak pulses, and decreased urine output because the kidneys aren't getting enough blood.
So let's talk about the drugs. The big one is digoxin.
The big one. Digoxin makes the heart muscle contract more forcefully. It's a positive inotrope, so it increases cardiac output, which helps get rid of all that backed up fluid.
And for the NCLEX, you absolutely have to know the safety parameters.
Non-negotiable. You must hold the dose and call the provider if an infant's apical pulse is less than 90 to 110. For an older child, it's less than 70.
And how do you know if it's toxic? What are the signs?
In kids, the number one most common early sign is vomiting. That's a huge red flag. Also bradycardia, nausea.
And there are strict rules for giving it, right?
Yes. It always needs a second nurse to double-check the dose. Always give it the same time every day. If the kid spits it up or vomits, you do not give another dose.
Okay. Now, how does that connect to diuretics like furosemide or Lasix?
This is a critical safety loop. Lasix makes you pee out fluid, but it also makes you lose potassium. And hypokalemia low potassium makes the heart much more sensitive to digoxin. It dramatically increases the risk of toxicity.
So the nursing role is?
Teaching. You teach the parents about potassium-rich foods. Bananas, oranges, green leafy vegetables.
And the third drug often used is an ACE inhibitor, like captopril.
Right. ACE inhibitors are vasodilators. They relax the blood vessels, which reduces the afterload, the resistance the heart has to pump against. It just makes the heart's job easier. The safety point there is watching the blood pressure very closely for hypotension.
What about non-drug interventions, especially with feeding?
This is all about conserving energy. First, daily weights. Same scale, same time every day. It's the best way to track fluid status. And you have to weigh their diapers for accurate output.
And calories.
We need to boost the calories without boosting the volume. So we'll concentrate the formula maybe from 20 calories per ounce up to 30.
And there's a strict time limit on feeds. Why is that 30-minute rule so important?
It is an absolute rule.
Yeah.
You limit the feeding to no more than 30 minutes. Any longer than that, and the baby is burning more calories trying to eat than they're actually taking in. It creates a net loss.
So they'll never gain weight.
Never. So we do smaller, more frequent calorie-dense feeds every 3 hours with a hard 30-minute stop.
Okay, fantastic. Let's pivot now. We're moving to group 2, decreased pulmonary blood flow, DPBF.
Odal pivot. We're going from the problem of too much blood in the lungs to not nearly enough. The big idea here is an obstruction. Something is physically blocking blood from getting to the lungs.
And that obstruction builds up pressure on the right side of the heart.
So much pressure that it forces a right-to-left shunt. Deoxygenated blood from the body gets shunted across a hole, like a VSD, into the left-sided circulation. It goes out to the body.
So the result is the baby is blue.
Cyanotic.
Profoundly cyanotic. And living in that chronic state of low oxygen triggers a bunch of compensatory things. The body makes way too many red blood cells to try and carry more oxygen. That's polycythemia. Yeah. And over time, you see clubbing of the fingernails, and these kids will often instinctively squat down.
Why squatting?
Well, I'll get to that. It's a brilliant compensatory move.
Okay, let's talk about the classic cyanotic defect, tetralogy of Fallot, TOF. There's a mnemonic for the 4 defects, right? PRV.
PRV, gotta know it.
Yeah.
P is for pulmonic stenosis. That's the main obstruction. R is for right ventricular hypertrophy because the RV is working so hard against that stenosis. O is for an overriding aorta that sits right over the VSD. And V is for the ventricular septal defect itself.
And you said before that the severity of the pulmonic stenosis really dictates everything. It's the driver. If the stenosis is mild, the shunt might be minimal, and the baby is only a little bit blue, a pink tet. If it's severe, almost no blood can get to the lungs, forcing a huge right-to-left shunt. These babies are deeply cyanotic, especially as their ductus arteriosus starts to close after birth.
What are the other key findings?
You'll hear a loud systolic murmur in the pulmonic area. And the chest x-ray is classic. It's a boot-shaped heart because the hypertrophied right ventricle makes the heart look like a wooden shoe, a saped.
Okay, let's talk about the emergency. The hypercyanotic spell, the TET spell.
This is a life-threatening event. The baby suddenly becomes profoundly cyanotic and distressed. It happens when the muscle right under the coronary valve goes into a spasm, completely cutting off what little blood flow is getting to the lungs.
And the nursing interventions here are critical, and the order matters.
The order is everything. And it might seem counterintuitive. The very first thing you do before you even reach for oxygen is physical.
The knee-chest position. Why does that work? Why is that number 1?
Okay, this is the physics of it. Putting the baby in a knee-chest position or having an older child squat does one main thing. It kinks the femoral arteries and dramatically increases systemic vascular resistance, SVR.
So it makes it harder for the heart to pump blood out to the body.
Exactly. So now when the right ventricle contracts, the blood has two choices. Go across the VSD into that now super high pressure aorta, or try to squeeze through the narrowed pulmonary valve. By jacking up the systemic pressure, you make the path to the lungs relatively easier. You are literally forcing more blood into the lungs.
That's brilliant. So the order of interventions is
Number 1, knee chest position. Number 2, administer 100% blow-by oxygen. Number 3, give morphine, which helps relax that infundibular spasm and calms the baby. And number 4, keep the child calm, reduce stimulation.
perfect. Now, you mentioned polycythemia, all those extra red blood cells. What's the big nursing risk associated with that?
The blood becomes thick, like sludge. And thick, viscous blood has a very high risk of clotting. So the number one long-term nursing priority for any child with chronic hypoxia and polycythemia is you must prevent dehydration
Because dehydration would make the blood even thicker.
and dramatically increase the risk of a stroke.
Got it. When do they do the full surgical repair for TOF?
Usually between 1 and 2 years of age, but they'll do it much earlier, around 3 or 4 months, if the baby is having a lot of TET spells. Long-term, many of these patients end up with a leaky pulmonary valve and will need another surgery to replace it years down the road.
Okay. What about just plain pulmonic stenosis without the other parts of TOF?
As an isolated defect, it's just a narrowing of that pulmonary valve. It obstructs blood flow to the lungs and makes the right ventricle work harder. A mild case might have no symptoms. A severe case can cause right-sided heart failure. The treatment is usually a balloon valvuloplasty in the cath lab to stretch the valve open.
And then there are the most severe obstructions, atresias.
Right. Pulmonary or tricuspid atresia. This means the valve never firmed at all. It's a solid sheet of tissue. There's no path for blood to get from the right ventricle to the lungs or from the right atrium to the right ventricle.
So survival depends completely on keeping one of those fetal shunts open.
It's the only way. The only way blood can get to the lungs is through the patent ductus arteriosus. So the second this diagnosis is made.
What's the immediate life-saving intervention?
An immediate and continuous 4V infusion of prostaglandin E1, PGE1. It's life support. It keeps that ductus arteriosus open, which is the only thing keeping the baby alive.
Okay. Moving on to group 3, the mixed defects.
The mixed defects. This is where oxygenated and deoxygenated blood are just freely mixing together somewhere in the heart. The result is always cyanosis, but you often get a component of heart failure, too, from all the volume overload.
And survival here also often depends on some kind of connection between the two sides.
It does. Let's take the classic example, transposition of the great arteries, PGA.
The great vessels are switched.
They're completely switched. The aortic comes off the right ventricle, and the pulmonary artery comes off the left ventricle. So you have two completely separate parallel circuits that don't connect.
That sounds incompatible with life.
It is,
Yeah.
unless there's a place for the blood to mix. The unoxygenated blood just keeps cycling to the body, and the oxygenated blood just keeps cycling to the lungs. The hallmark finding is severe, profound cyanosis that does not get better with oxygen.
Because the oxygen isn't getting into the systemic circulation.
It can't. So what do? We have to create a mixing point. We immediately start PGE1 to keep the PDA open, and then, often in the cath lab, they'll do an emergency procedure to rip a hole in the atrial septum, creating a large ASD for mixing.
And then a full surgical repair.
Yep, the arterial switch operation, usually in the first few weeks of life.
What are the other two mixed defects we should know?
Total anomalous pulmonary venous return, or TAPVR. This is where all 4 pulmonary veins carrying the good oxygenated blood connect back to the right atrium instead of the left. So all the blood in the heart is mixed. Survival requires an AST to get some of that blood to the left side.
Okay, and the last one.
Truncus arteriosus. Instead of a separate aorta and pulmonary artery, there's just one single great vessel, the truncus,
Yeah.
coming off the heart over a large VSD. All the blood mixes and then goes out this one pipe. These kids get into severe CHF very early because the low-resistance lungs steal most of the blood flow.
Got it. On to our final category, group 4, obstructed systemic blood flow.
Right. So now the problem is a blockage on the left side of the heart. Something is preventing blood from getting out to the body.
So you'd expect poor perfusion, weak pulses.
Exactly. Decreased cardiac output.
Right.
And the left ventricle has to work incredibly hard so it gets hypertrophied. And all that pressure backs up into the lungs. So you can actually see pulmonary congestion, even though the primary problem is an obstruction.
Let's start with coarctation of the aorta, COA.
This is a sharp narrowing, like a pinch, in the descending aorta. usually right near where the ductus arteriosus was. It creates two completely different pressure zones in the body.
A tale of two halves.
That's it. High pressure before the pinch, so high blood pressure in the head and arms, and low pressure after the pinch, so low blood pressure and weak or absent pulses in the legs.
So the single most important nursing assessment.
Is to take blood pressures in all four extremities. That's the test question. You're looking for that classic disparity, high in the arms, low in the legs. Older kids will complain that their legs get weak and painful when they exercise.
And in a newborn, this is an emergency when the DA closes?
It is. The lower half of the body loses its blood supply. So again, what's the life-saving drug?
PGE1 to open that ductus back up.
Exactly. Reopen the DA to perfuse the lower body until they can get to surgery or the cath lab for a balloon angioplasty. And these patients need lifelong follow-up because they have a high risk of developing hypertension later in life.
Okay. What about aortic stenosis?
Yes.
Oh, wait. Similar idea. But the narrowing is at the aortic valve itself. It obstructs flow out of the left ventricle. The LV gets hugely hypertrophied. These kids might have weak pulses, and older kids can present with chest pain or dizziness when they exercise.
And the most severe one in this group?
Hypoplastic left heart syndrome, HLHS. It's a catastrophic defect where the entire left side of the heart, the left ventricle, the aorta, is underdeveloped and basically non-functional.
So the right ventricle has to do all the work for the whole body.
All of it. The right ventricle pumps blood to the lungs, and then it relies entirely on the patent ductus arteriosus to shunt that blood backwards into the aorta to supply the body. Survival is 100% ductal dependent.
So PGE1 again?
From minute one, it is absolute life support. The only treatment options are a heart transplant or a series of 3 incredibly complex stage surgeries, the Norwood, the Glenn, and the Fontan.
And those surgeries don't create a normal heart. Not at all. They replumb the circulation to create a single ventricle physiology. It's a huge nursing challenge to manage these kids post-op, balancing how much blood goes to the lungs versus the body. It's a razor's edge.
Wow. Okay, we've covered the 4 big congenital groups. Let's do a quick review of the 2 big acquired heart diseases, rheumatic fever and Kawasaki.
Perfect. Let's start with rheumatic fever. This is an inflammatory disease that happens a few weeks after an untreated case of strep throat.
So it's an autoimmune reaction.
Exactly. The body creates antibodies to fight the strep bacteria, but those antibodies get confused and start attacking the body's own tissues, specifically the heart valves, the joints, and the brain. It's called molecular mimicry.
And the most serious permanent damage is to the heart.
It is. Rheumatic heart disease, permanent scarring, and damage to the valves, especially the mitral valve. The diagnosis is based on the Jones criteria. You need proof of a recent strep infection, plus a combination of major and minor criteria.
Let's hear the major criteria.
There's a good mnemonic, CANESC, for carditis, inflammation of the heart, A for arthritis, painful migratory joint swelling, N for subcutaneous nodules, E for erythema marginatum, a specific kind of rash, and S for Sydenham's chorea, those involuntary movements.
And the treatment is all about preventing that permanent heart damage.
Right. You give penicillin to kill any leftover strep and aspirin for the inflammation. But the key is long-term prevention. If there's any valve damage, that child needs prophylactic antibiotics, often for life, before any dental work to prevent infective endocarditis.
Okay, now Kawasaki disease, KID.
Kawasaki is an acute systemic vasculitis, inflammation of all the blood vessels. We don't know what causes it, but it's an emergency because of one specific devastating complication.
And that is?
Coronary artery aneurysms. It happens in up to a quarter of untreated kids. The arteries that supply the heart muscle can get these huge ballooning aneurysms that can rupture or form clots, leading to a heart attack.
So how do you recognize it? What are the signs?
It happens in phases. The acute phase is the key. It's a high fever for more than 5 days that does not respond to Tylenol or antibiotics, and you see a classic set of symptoms. Red eyes without any pus, red swollen hands and feet, cracked lips, and a bright red strawberry tongue. The kids are miserable and extremely irritable.
And after the fever breaks?
That's the subacute phase. They're still super irritable, and you see the skin start to peel off their fingertips and toes.
What's the critical treatment?
High-dose forts, immunoglobulin, IVIG. It has to be given within the first 10 days to calm down that inflammation and prevent the aneurysms. And you also give high-dose aspirin.
Aspirin in a kid? I thought that was a no-no because of Rey syndrome.
It is, and this is the one major exception. You use high-dose aspirin for its anti-inflammatory effects during the acute phase. Then you drop it to a low antiplatelet dose to prevent clots. But you're right, the safety point is huge. You have to teach parents to stop the aspirin immediately if the child gets sick with a virus like the flu or chickenpox.
That's a crucial point. Okay, last big section. Let's talk safety around a cardiac catheterization.
All right. Pre-procedure, the most important thing is to establish a baseline. You need to assess and mark the pedal pulses on both feet so you have something to compare to afterwards.
And post-procedure, what's the absolute fine thing you check when they get back to the floor?
The pulse distal to the site. If they went in through the right groin, you check the right pedal pulse. Is it there? Is it as strong as the left? That's your immediate check for perfusion. Then you check the color and temperature of that leg. Coolness or paleness is an emergency. It means you might have an arterial occlusion.
How long do they have to lie flat?
At least 4 to 6 hours, with the leg kept straight. Strict bed rest.
And what if it starts bleeding? What's the priority action?
This is a classic question. If you see bleeding at the site, you apply direct, continuous pressure 1 inch above the insertion site. Not on it, but above it. That's where the artery actually enters, and that's where you need to apply pressure to stop the bleed.
And what about fluids?
You keep the IV fluids going until they're drinking well. It's so important to keep these kids hydrated, especially the cyanotic ones with polycythemia, to prevent that risk of stroke.
Perfect. We've been through so much. Let's boil it all down. Give us the 10 absolute must-know facts for the exam.
Okay, rapid fire. Here we go.
Fetal circulation. The umbilical vein has the oxygen. The ductus arteriosus closes because of increased OXYGM.
Got it.
2. CHD timeline. Symptoms often pop up at 4 to 12 weeks after the fetal shunts close for good.
Okay.
3. VSD. Most common defect, loud, harsh systolic murmur. Untreated, it risks Eisenmenger syndrome.
Right.
4. Digoxin safety. Hold for an infant if the HR is under 90 to 110. Vomiting is the #1 sign of toxicity.
Crucial.
5. Heart failure loop. Lasix wastes potassium. Low potassium increases digoxin risk, and limit feeds to 30 minutes.
Makes sense.
6. TET spell emergency. First action is knee-chest position to increase SVR. 7. Chronic hypoxia. Polycythemia means high stroke risk. Your priority is to prevent dehydration. 8. Coarctation of the aorta. The assessment is BP in all 4 extremities. Look for the disparity.
The tale of two halves.
9. Life support. For any ductal-dependent lesion, the answer is a continuous infusion of prostaglandin E1.
Okay.
And 10. Cardiac cath bleed. Apply direct pressure 1 inch above the site.
Fantastic. Now let's see if that logic sticks. Time for a quick recall quiz. You ready?
Let's do it.
Question 1. A 6-month-old with CHF is due for digoxin. You check the apical pulse, and it's 95. What is your priority action?
The priority action is to give the medication. The hold parameter for an infant is below 90 to 110. 95 is in the safe therapeutic range. You give the dose.
Perfect. Question 2. A toddler with tetralogy phallic has a TET spell during a blood draw. What do you do first?
First, immediately you put that child in the knee-chest position. That is the priority. It's the physical maneuver that changes the hemodynamics. Oxygen and morphine come next.
Excellent. Question 3. Which category of CHD gives you a baby who is acyanotic, not blue, but has wet lungs, fails to thrive, and gets lots of pneumonia?
That is the classic picture of an increased pulmonary blood flow defect, a left-to-right shunt, like a VSD or PDA.
You got it. Question 4. You're assessing a child after a cardiac cath, and the dressing is suddenly soaked with blood. Where do you apply pressure?
Firm, continuous pressure, 1 inch above the insertion site.
Perfect. Last one. Which specific defect is known for a continuous, machinery-like murmur and a widened pulse pressure?
That's a PDA, the patent ductus arteriosus. The continuous shunt throughout the whole cardiac cycle creates that unique sound and affects the pulse pressure.
You've just aced a deep dive into pediatric cardiology. We went from fetal circulation through all 4 hemodynamic groups, IPBF, DPBF, mixed, and obstructed.
And the goal, remember, isn't just to memorize these names, it's to see the pattern. If you understand the physics, you can predict the symptoms. Shunt to the lungs, congestion, shunt away from the lungs, cyanosis, blockage leaving the heart, poor perfusion.
It all comes back to the direction of flow. So here's a final thought to leave you with. We talked about the Fontaine procedure for single ventricle kids. Their journey doesn't end there. As you continue studying, look up a unique long-term complication they face called protein-losing enteropathy. It's a fascinating and challenging consequence of that unique circulation.
So take these notes, go over those 10 facts, and just keep applying that clinical logic. You are way more prepared for these scenarios now.
That's all for this deep dive. We'll see you next time.